Thank you very much. I want to welcome everyone to the opioid crisis across the globe, which is an expert panel discussion, which is being presented and provided by Penington Institute out of Australia. I want to start by saying good morning, good afternoon, and good evening. Not very often you can do a webinar and be able to say that, but today we can actually say that as we are approaching Opioid Overdose Awareness Day in all countries. But I will begin by acknowledging that many of the people participating today are doing so from regions where the land they're participating from is traditional land of Indigenous peoples. I want to acknowledge the uniqueness of this situation and extend that acknowledgement to the land from where our participants are located. Secondly, I would like to thank Penington Institute for providing the work for this webinar and the background. And I want to thank them as well for the work they do to bring awareness of the drug overdose situation around the world in particular, and advocacy for drug awareness and addiction through their work in Australia. Please check out their website for more information on their work and their annual overdose awareness report, which John Ryan will speak to a little later on. Secondly, I want to thank the panel of participants who bring a wealth of expertise and knowledge to a challenging issue facing almost every country to one degree or another. And in particular, thank each of the registrants today. At the moment, there are more than 600 people participating. And we can see people from organizations in the United States, Canada, Australia, United Kingdom, Sweden, Finland, Greece, Germany, and Cyprus. So today we will have a number of different participants. We're going to start, and I'll do a short one-line introduction of each, and then I'll go back and ask them to go through their presentation. We have Dr. Carolyn Bennett, who's the ambassador to Denmark, Faroe Islands, and Greenland. She's a former minister in various portfolios in the Canadian government. And prior to that was a family doctor in Ontario, Canada. We have Parliament Secretary Elizabeth Briere. She's the Parliamentary Secretary to the Minister of Families, Children and Social Development, Parliamentary Secretary to the Minister of Mental Health and Addictions, and Associate Minister of Health in Canada. I don't think anyone would question whether she has enough work to do. We have Dr. Jeff Turnbull, Inner City Health, a member of the Order of Canada. He has served as the Chief of Staff at the Ottawa Hospital, educator, innovator have been terms used in describing Dr. Turnbull, and I often say friend, and the past decade has dedicated his life to some of the most vulnerable people in Ottawa, Canada. We have Jeremy Douglas, Chief of Staff of the United Nations Office on Drugs and Crime and the United Nations Office at Vienna, Strategic Advisor to the Executive Director of UNODC. Previously has worked in Southeast Asia and Pacific. Brad Finewood from Washington State, Strategic Advisor for Public Health, Seattle and King County, Washington. He's currently leading the overdose prevention efforts for Seattle and King County, has over 25 years experience in drug and alcohol field in both direct service and government. And he is a survivor of a brother who died of a drug overdose. We were scheduled to have Anke Stawitz, professor from the Protestant University of Applied Sciences, Freiburg, Germany. However, she is now ill, so she will not be participating. She did provide me with her notes, and I will read those later on. And we already have questions that have started to come in, and she's provided an answer to a question that was asked specifically of her, and I'll provide that response. So unless there's any questions from our panel, we'll start with Dr. Carolyn Bennett. Ambassador Dr. Honorable Carolyn Bennett.
Just Carolyn. Thank you, Vern, and it's such an honor to be included in this fantastic panel. Bonjour, ma chère Elizabeth, and it's great to see Jeff and Jeremy and Brad and all the others on this truly important day where we get to raise awareness of the facts and put in place, hopefully, some evidence-based strategies to address the tragic epidemic of overdose and overdose deaths around the world. On Wednesday, I visited the inspirational Rasmus Koberg Christensen at Penington in Copenhagen, probably the largest safe consumption site. And he was very clear. And I think this is a little bit about what we're talking today, is that the greatest obstacle right now to overdose prevention is the polarization between harm reduction and treatment. He held up one hand of harm reduction, the other hand of treatment, and said these are inextricably linked. And I think that we are very much now facing a real difficulty in terms of the ideology and judgment versus the care that will save lives. So it is about stigma and stereotypes and some horrific assumption that these deaths were inevitable. Even as this epidemic is closing in around our families and our loved ones, it makes no sense. And years ago, when we set up the Public Health Agency of Canada, we were committed to putting the public back into public health. We knew we had to bring the people with us. As the Minister of Hand Washing, we knew that people who'd seen the movie Outbreak thought people from CDC and Atlantic could arrive and fix things. And we know that's not true. We know that citizens need to understand the facts. We need citizens with them, us. And as Dr. Tam from the Public Health Agency says about pre-bunking mis and disinformation, that may not be possible in addressing this deadly crisis, but we have to try. We have to try and get the public on side and get the politics out of it, get the public on side with the facts. And I think that in Canada, we have had great groups like Moms Stop the Harm, who are doing an amazing job telling the stories of the loved ones lost to overdose. This business of common sense tells us is getting us into trouble. We've got anecdotes instead of qualitative research, and we know that we need that data matters, but words matter too. And I am a bit concerned that we're using the word safe and that people are fighting us with the word safe. So safe consumption sites, safe injection sites, safe supply. That it was interesting last year when we were in Lisbon and Berlin and Geneva, that words like substitution therapy or overdose prevention and recovery connection sites, we have to do better with the words, and we have to be able to tell the stories that put a human face on those whom we lost and those we are still losing every day. In talking to different audiences, I often, or difficult audiences, I often start with my husband's Peter's story, who was abused in a boarding school in England as a boy. The young man a year behind him ended up having his stomach pumped for alcohol poisoning at 14, then homeless on the streets of Edinburgh for a decade. And I think we know that if that had happened now, he may well have died because of the poisoned drug system and the difference of the substances that people are using to numb their pain, numb their physical pain from falling off a roof, or their psychic pain from abuse, and that we have to be bringing Canadians and people around the world with us when we say we've got to start asking a better question, not what's the matter with that person, but what happened to that person. I think when it comes to harm reduction, that we have to remind ourselves about HIV and AIDS when that was a death sentence and people were fighting the harm reduction of needle exchange or condoms, thinking we were condoning the behavior. And now with drugs and the poison drug supply, we know that you've got to live long enough to get treatment. But even the legal obstruction in too many countries for the even distribution of naloxone seems to be in the same frame of condoning a behavior. So we know that not everyone who dies of an overdose is addicted to drugs, and not everyone who's addicted to drugs is ready to stop using. And the decision to keep using can't be a death sentence. And neither of these things can operate in silos. So we know that safe consumption sites can be a gateway to drug treatment, but people, as so many of us continue to say, you cannot enter drug addiction treatment if you are dead. And so it is, I think we're in this together. Like COVID, the crisis doesn't respect borders, but there are huge differences country to country to the challenge. In Denmark here, it's mainly cocaine. There's some heroin, some speedballs, even with methadone. In Portugal, it was heroin. In North America, the deadly fentanyl, and now laced with the benzos that make the resuscitation more difficult and the withdrawal more unpredictable. Last year, after the WHA in Geneva, I was really inspired by meeting with Alexis Godsiel, the executive director of EMCDDA, the European Monitoring and Center for Drugs and Drug Addiction, which has this early warning system, 29 countries, 1 new substance a week. And he was then explaining about their responsibility in monitoring preparedness, capacity development, international cooperation, anticipate, alert, respond, and then an assessment in the country. That agency has been renewed this year as the EUDA, and again, that they are focusing on the EU preparedness on drugs through the 4 main actions, a little bit different: anticipate, alert, respond, and learn. And it is the task to be providing the EU member states with factual, objective, reliable, and comparable information, early warnings and risk assessments, and to recommend concrete evidence-based measures to address the challenges in an efficient and timely manner. They released a report last December on drug consumption rooms in Europe that suggested that DCRs may well have a beneficial impact on the level of access to healthcare and harm reduction services. Among those hard to reach target groups, they don't increase the crime in the surrounding areas, may contribute to decreasing drug use in public spaces, as well as reducing overall public nuisance. There is also, it said, some evidence indicating that drug consumption rooms can reduce drug-related deaths. So it really was in Lisbon, seeing the 20 years of heroin dissuasion, just navigating people to help. With methadone, it's pretty straightforward. But what I found really interesting and inspiring was by offering methadone, that you were also being able to help with the other complex medical conditions, that whether it's HIV/AIDS, whether it's Hep C, whether it's antipsychotic meds, that as people came for their methadone, they were given the other care and compassion, and yet again, I think demonstrating the importance of connection, that celebration when somebody's Hep C treatment is over and that they are cured, that this is about people who know your name and want you to stay alive. And so I think one of the things that we've been aware of is, as the reduction of drug use by injection, that we are not keeping up with the availability of inhalation sites, and that was very impressive in Copenhagen this week. Having communal, well-ventilated inhalation space, as opposed to what I think people have been trying, which is to replicate the injection individual desks and putting in a very expensive fume hood. It seems that these communal spaces are much less costly, and in some places, I know in Canada, they're still just using a picnic table outside. So it seems that here in Europe, that they've been worrying and expecting fentanyl for over 5 years, but here, when it's cocaine, it's mainly they need spaces to help people sleep it off, but and also the drug testing capacity. And unfortunately, recently they found the U.S. import of a vaping product for cannabis, which actually did have fentanyl. Here in Copenhagen, they since 2012, they've seen about 3 overdoses a week, 1,400 overdose, no death. It's open 22 out of 24 hours a day. And there's a treatment team available within minutes to respond to someone who's wanting to know about a pathway to a different life. And I know when we were in Washington State, they were talking to us about people just saying, where's that Suboxone lady? And if you can't do it right now, we know that window is very short, and that we've got to do much better at getting being able to respond right away. So I'm concerned that here only health providers can administer naloxone. They have to wait till the health provider arrives. And I'm concerned that last year at the meeting in Washington on fentanyl precursors, that Mexico had huge hesitation in using naloxone with, again, that ideology about condoning behavior, which is that flashback to HIV/AIDS. So I think that people need to know that in Canada, the Carpenters Union is handing out naloxone kits to the new recruits. It's available in the pharmacies all across Canada. But I guess in conclusion, I just want to say people are wondering why the ideology trumps, pardon the pun, the economics. I think lots of people are asking me, why aren't the fiscal conservatives with us in terms of ambulance costs, ER costs, here sociolances, the crime, that the need and the cost effectiveness of safe, affordable, and supportive housing, spaces where people feel safe and can build trusting relationships that help them. I think that this prescribable housing now at the UHN in Toronto is interesting, but I guess I just want to say that we have to continue the fight for evidence-based, culturally safe, trauma-informed care. We have to replace the ideology with education and facts, isolation with connection. And as this epidemic closes in on our friends and families, we need to find those teachable moments, that those moms stop the harm voices, bring the people with us, put the public back into public health, and move this health crisis out of the criminal justice system to help people using drugs to live their best lives.
Thank you very much, Dr. Bennett. Now we'll move on to Madame Ria, s'il vous plaît.
Thank you. Thank you so much. And Dr. Bennett, it's so great to see you again. Good morning. Bonjour à tous. International Overdose Awareness Day is an opportunity to remember those we lost to substance use and to recognize the pain of families and friends who have remained in the shadows. In Canada, the overdose crisis continues to have devastating effects on individuals, families, and communities. According to our latest data publication, there were more than 44,000 deaths due to opioid toxicity between January 2016 and December 2023, or 22 deaths per day. That is why we must continue to work together at all orders of government, including Indigenous communities and people with lived and living experience, as well as their families and communities, to save lives, because together we can. The Government of Canada's approach to addressing the overdose crisis supports a continuum of care across prevention, harm reduction, treatment and recovery, and enforcement. The goal is to improve the health and safety of all Canadians by minimizing overdoses and related harms for individuals, families, and communities. This continuum of care is key, and we need to continue to balance harm reduction and treatment and not just invest in one or the other. Parmi les efforts déployés par le gouvernement du Canada pour faire face à la crise des surdoses, citons les 26 millions de dollars alloués par l'intermédiaire du Programme sur l'usage et les dépendances aux substances, PODS, pour de la distribution des kits de naloxone et la formation aux surdoses d'opioïdes dans l'ensemble du pays. Grâce à ces investissements, 2,2 millions de personnes ont été formées au Canada sur la manière de réagir à une surdose, et plus de 92 000 kits de naloxone nasal ont été distribués dans tout le pays. Ce n'est là qu'un des nombreux projets qui permettent de sauver des vies à chaque jour. To address the harms caused by stigma, the Government of Canada has also recently relaunched the Ease to Burden campaign, which shares the message that it takes strength to ask for help, and promotes free resources for men working in trades who are struggling with substance use and addiction. We also know that the provinces and territories our Indigenous partners and municipalities need a range of tools and support to develop a comprehensive approach to the overdose crisis. Budget 2024 provided $150 million over 3 years for an emergency treatment fund open to Indigenous communities, municipalities to help provide rapid responses to emerging and critical needs related to the overdose crisis. The Emergency Treatment Fund builds on our historical investments in healthcare, including $25 billion over 10 years to the provinces and territories to support access to quality mental health services and substance use, as well as other shared healthcare priorities. We also recognize that to deal with the overdose crisis and the harms related to substance use, we must also look upstream and respond to the root causes of substance use while protecting the most vulnerable people, our children. We have created a new program to prevent the use of substance among young people, adapted from the Icelandic prevention model. The Icelandic model is a world-leading model, and its implementation in Canada will aid many youth across the country. Alors que la crise des surdoses continue d'évoluer, on doit continuer à soutenir la recherche pour développer des interventions fondées sur des preuves et collecter des données pour améliorer notre compréhension des tendances de l'approvisionnement en drogues illégales afin d'informer notre réponse. While I have shared just a few examples today of the critical work underway to address the overdose crisis in Canada, we know that still more needs to be done to both protect the health and safety of Canadians and support the family, friends, and communities who have lost loved ones to an overdose. We also know that we need to continue to invest in this crisis and that continued funding is critical to the work we are doing and that we continue to do, which saves lives each and every day. I look forward to learning more today about how we can move forward together to address this tragic crisis. Thank you. Merci.
Thank you very much, Elizabeth. I appreciate it. Now I'll ask Dr. Jeff Turnbull to jump in. If you are ready, sir.
I'd like to thank the Penington Institute for organizing this and inviting me. It's a great honor, so thank you very much. The perspective I bring is for 20 years working with my colleagues, caring for those people experiencing homelessness within Ottawa. And during that period of time, we've seen a dramatic change in mental health, addictions, and the complications associated with them. What we have not seen, unfortunately, is dramatic improvement. We haven't seen investment in strategic priorities such as mental health and addictions, supportive housing, education. And as a result, we've seen a persistent and long-standing problem with homelessness, addictions, and mental health. And so to begin and turn our attention to the overdose crisis that we're all dealing with, it's important to point out that this didn't just happen in 2016. It happened within the background of progressive overprescribing. As a physician, I'll say that. We underfunded mental health, we underfunded addiction treatments, we underfunded housing. We didn't have comprehensive programs for identification of individuals at risk. And lo and behold, in 2016, the opioid crisis came within that context. So it's important to recognize that this is not just new. As was mentioned by Elizabeth, Canada has, from 2016 to 2023, there's been 44,000 deaths, which is important to recognize that that's about 22 deaths per day in Canada. And if you look at that, that's year on year, For example, last year, 8,000 deaths in Canada. That's a 7% increase. But it has other implications, as Carolyn mentioned, to other healthcare providers. So, for example, hospitalizations are up 14%. Emergency response also up 18%. So these are enormous implications that have tremendous costs, and it's behooves all of us to try and minimize those costs and provide the best supportive care. So the impact has been huge upon all of us in those people who provide health services. I should say that even though those numbers are showing progressive increases, there is some light at the end of the tunnel. And that, for example, in Alberta, there has been a 50% reduction in the number of deaths. BC, another province in Canada, a 9% reduction in the number of deaths. Now, maybe this is just a blip, but on the other hand, there is some degree of optimism that some of the efforts to date have been successful and are at least blunting the progressive increase of deaths as a result of a toxic drug supply. Speaking of that, then in Canada, and I think it's important to recognize, and we've already heard, that drug overdose, substance use disorders are very regional. It wouldn't be the same Ottawa to Toronto to a rural community, and it's certainly not the same between Canada and other jurisdictions around the world. So it's important to recognize that these issues are very regional and specific to communities. But for us in Canada, fentanyl is the major cause of death. It's there about 82% of the time in fatal drug overdoses. But what's happened more recently, we've gone from prescription opioids, a brief period of time when we were dealing with heroin, particularly in Ontario. Crystal meth has become quite prominent. And then we went to fentanyl. And from fentanyl, we've gone to a toxic drug supply where we find that our fentanyl has varying degree of toxicity, potency, and is now mixed with many different other drugs, in particular benzodiazepines. And so that makes resuscitation that much more complicated. And as a consequence of that, in Canada, interestingly, we're seeing in some circumstances, some settings, a reduction in the life expectancy. For the first time in Canada, we've seen always progressive increase in life expectancy, and now we're starting to see that slow. And that could either be, and is likely to be both, COVID and our drug overdose. And again, remember that this is about the most common population for us dealing with drug overdose deaths. It's the 30 to 40-year-old males most prominently, and that's a lot of life expectancy. That's a lot of, opportunity that's been lost to our community and to families and individuals. So, and then the last thing I wanted to point out in this context is that during the COVID crisis, we saw that there was an increase in our overdose deaths, and that was because probably twofold. One is stress and isolation and the withdrawal of associated services. So the combination of COVID plus the crisis from drug overdoses was particularly toxic for us in Canada. Our response, I think, is important to recognize that we've emphasized to a greater extent harm reduction strategies. We've gone from needle exchange to naloxone. I like to think that if you close your eyes briefly trying to walk across the street at a red light, somebody's probably going to give you naloxone in Ontario. That it's made freely available and it's used commonly. But we have to remember as well that now with our very potent fentanyl or its metabolites, you need multiple doses of naloxone. We've had opioid substitution therapy widely available, from methadone to Suboxone, Sublocade, and long-acting opioids. We've had a safer supply initiatives, and we've had managed opioid injectable initiatives. We've also had enforcement strategies, but I think that our enforcement community is telling us that it's going to be very difficult to arrest our way out of this crisis. And then education is essential. It's important to recognize that treatment, a very important strategy here, has to be wraparound strategy. We have to be there providing services, not just for treatment and counseling, but we also have to provide housing. We have to provide support, mental health strategies. We have to provide all sorts of other required social services that would allow those individuals to functionally return to a community that they want to be part of. So I think in closing, what I'd say is that we have not funded comprehensive treatment strategies as we should. We have not targeted those communities that are at the highest risk in prevention strategies. We've often been timid. We've often been, I think, fighting amongst providers and politicians. There's a great deal of political pressure at this point in time to stop safe injection facilities, even though there's evidence that they save lives, because of the political pressure. And I think that that has to be resisted wherever possible. And I think, understandably, we have to understand this crisis that we're in, and that this is substance use disorders are chronic, relapsing disorders. They're often as a consequence of underlying trauma or mental health issues, and they, just have these devastating effects on individuals, families, and communities. But most importantly, I think it's also important to remember that it's the most vulnerable around us that suffers so much. And it's often individuals from indigenous communities, rural, remote settings, people who are disenfranchised in many other regards. But fundamentally, underneath that is poverty. And I think that unless we start to look at those underlying causes, we're always going to be trying to deal with addictions, mental health strategies, and we'll be on our heels. And for us to be effective going ahead in the future, we're going to have to deal with those problems. So I'll stop at that point in time and be happy to answer questions later.
Thanks very much, Dr. Well, great point in relation to, although it's a global impact, as we're hearing, the regional cause isn't always the same. Now we'll hear from Jeremy Douglas with UNODC, and thanks very much for finding time today, Jeremy.
Oh, thanks, Vern. And I'd like to personally thank you for inviting me back, or inviting me here. I recall our conversation first time I met you in Australia quite some years ago, and I was describing the drug situation at that time in the region, and pretty dramatic increase at that time in synthetic drugs. So I'm going to kind of, for everyone in this meeting, I'm going to reflect on that today, my time in that region and how I've seen it change. And since I saw you, Vern, it has changed significantly again, both expanding the supply, but also the types of drugs being used in the region have changed. And there are some warning signs, I think, that the region needs to look at, and they have to start considering some different options for themselves to respond. But just so everyone's aware, I worked in Asia Pacific starting in 2002, and then I came in and out of the region. And I spent the last decade there. I just moved here to our headquarters just late last year to take on the role as chief of staff. But prior to that, I was regional director. So I've seen the drug situation evolve rapidly in the region. And I guess a lot of you have heard of the Golden Triangle and the kind of impact of the heroin flows of the Golden Triangle on Asia Pacific. So really, you're looking at historically, that was the situation. But then about 2 decades ago, there started to be this surge of methamphetamine. But at that time, it was a very small surge, but nonetheless, there was a surge, a heroin market shifting towards methamphetamine. And then over the past decade, particularly, in large part driven by globalized global drug syndicates, organized crime, there was this supply push in Asia Pacific, which really flooded the region with high purity methamphetamine. So we went from this kind of pockets of methamphetamine use expanding slightly, pretty usually low quality methamphetamine. Suddenly high purity crystal methamphetamine started surging across Asia Pacific. And more recently, we've seen the expansion of ketamine in the region. Ketamine is a new psychoactive substance, but it's really kind of like, it's also a veterinary product, but or used in surgeries in some parts of the world. But the fact of the matter is that's also surging, produced by and large by the same syndicates in the same locations, largely in unstable areas of the region. And more recently, we've seen signs of NPS, new psychoactive substances, other than ketamine, coming into the market as well. But as we look further ahead, largely driven because of the instability in a place called Myanmar, Burma, where they have a civil war ongoing, we're seeing the resurgence of the heroin market. Poverty, of course, is deeply connected to drug production. And we're seeing a lot of people go back into opium farming, which is causing a heroin resurgence, which is potentially going to cause a supply push for heroin. And of course, that's a precondition for potentially synthetic opioids in the region as well. We have seen some indications of synthetic opioids in the market the past few years. There have, for example, been some overdoses which were dealt with in a very, very small pocket in Bangkok. Some seizures, actually some fentanyl in Canada was seized coming from Thailand to Canada. So it does move around the region, although it doesn't seem to make much of an impact on the region itself at this point in time. I think when you think, though, about Asia, and that's the broad strokes of the situation. When you think about Asia, it's, of course, incredibly diverse. A lot of us in this meeting are not from the region, but we often think of it as kind of monolithic. It's Asia. Everyone is kind of similar. Actually, that's not the case. You know, it's a very, very diverse region. A lot of different language groups, a lot of different variability in the countries and the economies of those countries, deeply entrenched poverty, with very limited services offered to the citizens of the region, particularly in places like Laos and Cambodia, in Myanmar, of course, where the country's in a free fall. And you have a very, very large population. You know, you have well over 2 billion people in the region that I was working in for those years. And it's also at the same time a source of drugs for the world, parts of the world, mainly the near neighboring region, Australia particularly, Japan, the kind of wealthier countries on the periphery. But at the same time, it's also the greatest source of chemicals to make synthetic drugs, which we see hitting North America or hitting Europe at this point in time. So when you talk about fentanyl in North America, it's deeply connected with the pharmaceutical or the chemical industries, typically of Asia, which requires and necessitates a conversation with that region about the situation within that region. And obviously dealing with the drug policymakers of that region to impress upon them that things need to be dealt with there. Just to give you a sense of the drug policy environment in Asia, it's really largely, or in some cases almost exclusively, focused on addressing supply. And this is due to the history of the region and the nature of the governments, the top-down approach, and the kind of authoritarian, often, I wouldn't say, but, you know, kind of like heavy-handed approach is very, very popular with the public. So there's this history of dealing with things on the supply side and really avoiding, if you will, the provision of public services, prevention services, treatment services, harm reduction services. And that's also because of cultural difference, where you see a lot of people, they tend to think in a more collective way than they do in an individual rights way. So the approach of governments is to cater to the collective logic and the collective interest in that sense. But the result of that is overwhelmingly crowded prisons. We see prison overpopulation rates that are incredible in parts of the region. For example, Thailand, where I just moved from, you have the prison population is multiple times over basically hundreds, a few 100% overpopulated. And if you look at Thailand alone, because of its predominant drug policy, it has about 40% of the prison population in the region, only 10% of the actual population in the region. So you have this massive population, almost all of which are in prison for drug-related offenses. That would be anything in the drug business, all the way from trafficking, all the way through to possession, all the way through to use, which is criminalized. And on the back of that, you have extremely limited treatment and harm reduction services. And that brings me to the approach of what do you do in an environment like that? How do you bring some balance? And I think you're familiar with, many of you be familiar with what the UN has been discussing over recent years. There's this UN General Assembly dynamic that took place back almost 10 years ago now, with a special session on the world drug problem and a call for balance to the world drug problem, including many of the measures which were mentioned by the preceding speakers. The thing is, though, the kind of balanced approach is hard to sell in that environment. And in the past, there have been many attempts to sell harm reduction or to sell treatment services in that environment, or convince the region to do so. But in effect, the approach that was taken failed. And why? It's because the approach of often people coming from outside the region to talk at the region has not worked. They haven't really considered what people are receptive to hearing. They haven't really considered how we can convince governments to move them in a different direction. But I must say we're making some headway in that space now. And because I think governments are seeing that they cannot continue with business as usual, particularly because the supply surge of the past decade continues to hit them. And only in the past 2 years, it's expanded yet again. We've just reported numbers that methamphetamine supply is up, heroin supply is rising, and they can't arrest their way out of this. So there's an acknowledgement that they need to move away from simply that one-dimensional approach towards providing services for communities, for harm reduction, in harm reduction space and the treatment space. Now, that brings me to how do we work with Asia on this issue? And given some of the economies of the region, as I mentioned, are very poor, or some of the countries are very, very poor, and the provision of services is very low, we need to bring very practical, low-cost solutions to a region like that, offering them advice on harm reduction services or treatment services that can get to people without great impact on budget, because there isn't much budget to work with. At the same time, practical prevention messaging, targeting largely youth about the dangers of the drug supply that is within the region or potentially coming to the region. And the other thing is really supporting data development. It was touched on by several of you about the need for data and an evidence base. It's really shallow in Asia. They don't study drug use as they do in other parts of the region. We don't have any MCDDA like Europe has. There's no monitoring system there in place. There's a peripheral one, which we have running there, but it's dependent on governments to feed into it. But really, data development and generation and management is crucial to this if they're going to make headway. The other thing is really supporting cooperation and exchange of best practices from other parts of the world or within the region itself. And there are some little pilots that have been run, which have been relatively successful, to share those examples and to make sure that governments are able to look at scalable options for themselves when it comes to offering services to people in the streets. And I think given what I said earlier about the potential resurgence of heroin, that's going to be really, really crucial, because with heroin, you bring with it injection drug use again. You bring with it which was very prevalent in the past, has subsided to some extent, but could come back, and also could potentially bring something like fentanyl into the region that could create those conditions for fentanyl. I think what can also Asia Pacific share with the rest of the world, as I said, there are some examples. I've seen some in Thailand. I've seen some in other parts of the region where they've had, because of the low cost interventions that are necessary, they've had the ability to, or had the necessity to look at those things and try to look at scale options. And I think they could share those experiences with some of yourselves. So that's something just food for thought for your panel there, Vern.
Thank you very much, Jeremy. I appreciate that. I appreciate it's always difficult, I think, for many to see the global perspective and the challenges that are faced in other countries. You know, often we talk about, well, why can't we stop drug trafficking in the country of the source country? But it's never as easy as it sounds, particularly in these poorer countries where a lot of people depend on the income that comes from the illegal growing and formulating of illegal drugs. Well, thank you very much for that. Now we'll jump to Brad Finewood from the Seattle and King County Public Health. Thank you very much again, Jeremy, and welcome, Brad.
Thank you, everybody. Can you see my screen okay?
We can.
Great. Thank you so much. I am a very visual person, and that's hence my excuse for needing slides today. What an honor it is to be here with this panel. My name is Brad Finegood, as was mentioned. I'm here today wearing multiple hats. My day job, I work for public health, Seattle, King County. I oversee the overdose prevention efforts for Seattle and our greater county. I also am faculty at Western Michigan University, and I co-chair a Big Cities Health Coalition work group on overdose prevention for the largest cities across the United States. But I think most importantly for me, why I'm here today is I am also the brother of, I'm the survivor of a brother who died of a drug overdose. And it was talked about earlier by Dr. Bennett that it's extremely important to be able to put a name and face to those who are dying of drug overdose. And for me, this is a very personal issue. This is a picture of my brother, Greg, Greg with 2 G's. He would always want everyone to know that he had 2 G's at the end of his name, which actually means he had 3 G's in his name. But my brother, Greg, was born on October 29th. He was a beautiful boy. He was 3 years and 2 weeks my younger. My brother Greg not only was a beautiful young boy as a child, but he was also a beautiful son to my parents. He was a beautiful brother to myself, and he was a beautiful uncle, as you can see here. This was my firstborn child. This is my firstborn child with my brother, spending quality time. These are the names and the faces and of the people who have died of a drug overdose. On New Year's Day, 2004, 2005, my family received a phone call from the Philadelphia City Hospital that my brother was found dead of a drug overdose. And there's nothing in my life that ever changed my life more. My brother was a college graduate. He was a well-functioning member of the community and society. And this is the last picture that I had of him. So for me, coming up on this New Year's, which will be the 20th anniversary of my brother's death, today, even more than ever, the cause and the call to action to remember those who have lost their lives to drug overdose and identify what more we can do rings louder and louder in the United States. For the first time in many years, from 2002 to 2003, we saw a small decrease in overdose deaths, but that decrease still of 3% still left us as many consecutive years, over 100,000 people in the United States dying of a drug overdose. And as was talked about earlier, this issue has a tremendous amount of variation across regions of the United States. In Seattle and King County, from 2002 to 2003, the rate of overdose continued to skyrocket. As you can see here, we pride ourselves on having real-time overdose data. As was discussed earlier, the need for data to inform our interventions and to inform the public, we take very seriously here. And through a cooperation with our public health department and our epidemiologists with our medical examiner's office, we make our real-time overdose data available to the public. In 2002, we had over 1,000 overdose deaths. Over 70% of those were fentanyl related. About just over 50% of those had polysubstance use, had fentanyl and some type of stimulant, and that number skyrocketed from 2022 to 2023. While the rest of the country was seeing a 3% decrease, we saw a significant increase, and that was continued to be driven by fentanyl. Fentanyl last year made up of our overdose deaths, and polysubstance use continued to drive overdoses and complicate the matter because, as we know, we have really effective treatments for those with opiate use disorder, but those who are using stimulants, it becomes much harder to treat. So here you can see when I first came to King County, it was in 2015, we had that dark blue line. There was 3 fentanyl overdose deaths in our county, counting 3 in our whole county, which was something that we were keeping an eye on, but nothing that caused the epidemic that it is today. Last year in King County, we had over 1,000 fentanyl overdose deaths. So in 8 years, that went from 3 overdoses involving fentanyl to over 1,000. It's really important to understand the disparities, as was talked about earlier. This slide, my epidemiologist would wring my neck for because it's way too much data in one slide. But in the upper left-hand slide, you can see AIAN, which is American Indian Alaska Native individuals, in 2022 had approximately a 7 times higher overdose rate than their white counterparts. That number dropped a little bit. The rate dropped a little bit last year to still 5%. And then Black individuals in our community were dying at about a 3%, have been dying at about a 3 times, not 3%, I'm sorry, about a 3 times higher overdose rate. The bottom right chart is the age of people dying of overdose death in King County, and this mirrors a lot of what we're seeing, especially on the West Coast of the United States. The highest rate of people dying of overdose death are not young people in our community, but our older community members, our elders, 45 to 65-year-old range, and the pink chart, which is the fastest growing percentage rate of people dying of overdose, are over the age of 65. So when we think about who's dying and how we target our interventions, we really need to think about the most impacted, especially those that are living unsheltered. So for us here, it's really been a perfect storm. We've seen a huge increase in the fentanyl drug supply. When counterfeit pills first came into our community with fentanyl, there was about $40 a pill. Now fentanyl pills are approximately $1 a pill. So it's cheaper and easier to get drugs than it is to get treatment, which we're trying to upend. And the drug supply is in plenty. Adding to that perfect storm is a changing route of administration. So people have been smoking drugs and no longer needing to use needles. Throw on top of that the COVID epidemic. Treatment agencies, their doors became shut. People became more disconnected. Information was harder to come by. And in addition to starting to see counterfeit pills, we're now seeing a lot more fentanyl come in the form of powder and rock form. It doesn't on the West Coast of the United States, we're not seeing it in cocaine that is powder or rock, but we're seeing it very much looking the same. So somebody might not have tolerance to opiates, but have a traditional use of stimulants, of cocaine, and taking fentanyl and dying inadvertently. And also the impacts of the housing market. We know that housing is extremely expensive, and it's pushed a lot of people to the street with it unaffordability. I don't know if that's a word. I can use the excuse that it's really early in the morning here, with the lack of affordable housing that happens. Additionally, as was said before, the regional differences drug use is extremely important here. We're starting to do some more community-based drug checking in the United States to understand the drug market in real time, both to improve the lives of people and the information that they have at their hands when they're using substances, but also from a surveillance perspective to understand what's in the drug market. The 2 drug samples in the middle these are all very recent from this month. The second one down is a fentanyl sample. These are all samples that were taken for people who believe that they were fentanyl. As you can see, there's other items in fentanyl, including xylazine a little bit, but it's pretty much predominantly fentanyl. The top sample from Michigan and the bottom sample from New York City, you can see that that on the East coast of the United States, the drug supply looks very different and has a lot of other types of substances in it, from both stimulants to multiple. On the top one, you can see it has fentanyl, heroin, and lidocaine, a stimulant in there. And on the bottom from New York City, you can see that the drug supply looks very different, and it looks very different regionally here. But it's not all doom and gloom. I think there is a lot of hope. So for us, in King County, we've seen a 15% decrease in overdose deaths year to date, which for us is a sign of hope, but it's also a sign of continued vigilance that maybe some of the things we're doing are working, and there may be other factors at play. We just don't know, but it gives us a sign of hope. In the Q3 of last year, we really started to top out. Some of the things that are happening for us that we're really putting a lot of time, energy, and effort. There's been a lot of conversation here about supervised use facilities, safer use facilities. As Dr. Bennett was saying, there's a lot of different languages to describe. In New York City, there's 2 facilities, and in the Northeast, there's been some recent legislation, but it's not as ubiquitous across the United States as it is safer use facilities in other parts of the world. But we also know that doesn't cause us, that it doesn't have us stop with our efforts. So we've really increased naloxone distribution. One of the mechanisms is a vending machine. Here you can see we co-created this vending machine with one of our peer agencies. We are really using a lot more medications for opiate use disorder. It is interesting, even between the United States and Canada, the different federal regulations that allow or limit the use of a substance like methadone, where it could be prescribed by doctors in Canada. In the United States, in standalone opiate treatment facilities. But we've started to deploy more mobile methadone units out in the community. I have a lot of hope, as was talked about earlier by Jeremy or by Dr. Jeff, around long-acting injectables, both Sublocade and Brixadi. We've seen a lot of hope with people who have received long-acting injectables because they have either a week or a month's worth of the medication in them, and they don't have to make that decision every day of, am I going to get high or am I going to take my medication, because their medication is always in them. We've started doing more teleprescribing. We have a 24/7 teleprescribing buprenorphine line that has been extremely popular and highly used since we started it at the beginning of the year. We're also trying to have more lower barrier care. Detox used to be the front end of our treatment continuum, and we know people don't necessarily want detox. A lot was said earlier about raising the voice of people with lived and living experience and program design, and reducing the stigma. And a great example of us reducing the stigma is the work that's here today. In closing, I just thought this picture, these 2 pictures was really important for me. The picture on the right is that of me and my brother at his wedding. When my brother died, one of the things that we learned most is about stigma and shame, and about how when people hide their substance use, that they live in that shame and stigma. My brother was my best friend. I saw him every day, and I had no idea that he had an opiate use disorder. When he died, we know that the person with him who was also using opiates and other drugs, failed to identify what an overdose looks like. So we know that if we can empower people who are also using opiates, that they are often the first ones on the scene. And so we've done a lot around educating people who use opiates around what overdose prevention looks like, and making sure that there's naloxone on hand. Like was said earlier, if there's no naloxone on hand, we can't keep people alive to help them find recovery. And there was no naloxone on hand, because my brother could be here today and my life trajectory would be very different. The picture on the left is me and one of my best friends, Thea, who's an overdose survivor. And for her, that ability to have naloxone, ability to have the overdose reversed, meant that she could be here with us today, meant that I get to go to work with her every day, and meant that the programs and the work that we do get to be driven by real factual evidence. and interventions that work. So again, in closing, it's just been an honor to be here and to have this time with you today. Thank you again.
Thank you very much, Brad. And again, my condolences on your loss. Professor Anka Stowitz from the Protestant University of Applied Sciences, Freiburg, was scheduled to be with us. She couldn't be, she's not feeling well, but she did send in a couple of words she would like me to read for, if that's okay. She states, from my perspective, the causes for drug dependence should be focused more, for example, poverty, socioeconomic marginalization, and social exclusion. Besides drug-related prevention and intervention approaches focused on individuals, the structural factors providing the social prerequisites for drug dependence and possibilities of further social inclusion should be addressed much more. Very important also is to include the people more in the design and development of drug policy in general and approaches to intervention, including prevention particularly. Participatory approaches in drug research, policy, and intervention are needed to develop efficient approaches that consider the affected person's life worlds and realities and their perspectives. In general, an open public discourse on drug overdose should be promoted to destigmatize the topic. So thanks to Anka for sending that in for us. I'm going to have John Ryan speak in a few minutes, but I do have some questions, and I know that Parliamentary Secretary Briere has to leave a little earlier than everyone else. So if it's okay, John, with you, I'll go to one question for her, and then I'll come back to you. Is that okay? I guess it's okay. Thumbs up. There we go. Thank you very much. So the question specifically for Elizabeth Briere is, as the Parliamentary Secretary to the Minister of Health, how do you justify the government's slow response to the overdose crisis, which continues to claim thousands of lives? What specific actions will you and the government take to ensure that harm reduction, safe supply, and decriminalization become central to Canada's national drug strategy rather than mere talking points?
Thank you. Thank you for the question. Well, all these subjects are very, very important. And I think that from the beginning, especially with the important work Dr. Bennett did as a former Minister of Health in Canada, and the first minister to be appointed as a Minister of Mental Health and Addictions, the whole Canada's approach to address the overdose crisis is based on the 4 pillars internationally recognized to say prevention, harm reduction, law enforcement, and treatment and recovery. So when we act in all 4 pillars, I think it's the best solution to help most people. It saves lives every day, and we have stats on that data. Of course, we still have more to do, and we are everywhere across the country having roundtable discussion like this one today, and discussion with all the stakeholders and every nonprofit organization working on the ground with people with lived and living experiences to make sure that our response is the best. So we'll keep monitoring the numbers, and we'll keep being there for all Canadians and adding some solutions, options to tackle this important crisis.
Thank you very much. The first question we'll go to on the list of questions we received prior, and then we'll jump to the Q&A. We've been receiving questions for the chat side as well. First question is for Jeremy Douglas. As Chief of Staff to the Director General of UNODC, how do you address the criticism that international drug policies have historically prioritized criminalization over public health, resulting in widespread harm? What concrete steps is the UNODC taking to shift toward a more humane, evidence-based approach, particularly in light of the global opioid crisis?
Well, I think as I touched on earlier, you know, there was a very, very big conversation with member states. So we're owned by our member states in 2016. It culminated in 2016 with a document which guides our approach globally. And actually, it sounds quite similar to the Canadian approach, to be quite frank, which in the sense that it's got the similar elements that were just described by Parliamentary Secretary Briere. And we very much and very strongly advocate for that. At the same time, fundamentally, drug policies are national. So we are pushing very consistently for what's called the UN General Assembly Special Session on Drug Problem, the World Drug Problem, to the UNGAS 2016 approach. But the member states go in different directions. There's a lot of experimentation globally. And I would say that it's very different in different regions of the world. There's different histories in different regions of the world, and therefore different approaches that are taken. But we are consistently advocating nonetheless for that position that I've described. I would also point out that if you read carefully the international drug conventions, they're fundamentally reflective of protection of public health. The challenge is the methods to protect the public health, which are debatable, right? So you have different states taking those different approaches, some of which involve extremely harsh measures, some of which involve very progressive measures. So there's a lot of flexibility in the interpretation, if you will, of the conventions taken by different member states. So we're pushing on the one side for the approach that was very strongly advocated for in the UNGAS. We have our offices around the world advocating consistently for that. We're building an evidence base to help member states to understand how they should approach to implement. And we're trying to raise resources with international partners, trust funds. We're working with governments to help them prioritize budget within government and also take measures to address not necessarily the direct impact of the drugs, but for example, to some of the underlying factors, or to address the prison overcrowding, or to address the sentencing through judicial systems. That is a situation and as I touched on when I talked earlier, very harsh sentencing for drug crime. So we're pushing on all these fronts, and we're trying our utmost to make sure that we advance this global drug policy shift that we had been working on before. My boss, the executive director, is leading the effort of that in the UN family. We have a global task team within the UN, which was convened by Secretary General Guterres a couple of years ago, and we have other elements, other partners within the UN, UNAIDS, WHO. They're all part of the same effort, reporting on the efforts that they make, and we're coordinating with them throughout this effort. Thank you.
Thank you very much for that. I do have one question that just came in through our chat side. Madame Briere, if you don't mind answering before you leave. Why is Ontario, Canada being permitted to close half of the supervised consumption sites by 2025? Came from one of our participants, one of our registrants.
Thank you again for this question. Well, first of all, I think that the situation in Ontario is pretty polarization. It's part of the polarization. And as Dr. Bennett said in our opening remarks, also, they want to close those facilities because they are too close of schools. So they will probably have a new law to avoid having those facilities close to school. And we hope that it will change and enable the other centers to be in zones more accurate. So we all want the same. We want for people and communities to be safe and secure, and for healthcare to be available for those who need it. Thank you.
Out of interest, Elizabeth, has there been research done on whether or not there is an impact based on the placement of the facilities? For example, I've read the announcement by Premier Ford surrounding closing the facilities that were near schools within, I think, 500 meters or 200 meters of a school. Has there been research done federally about the potential impact of these facilities being within a certain proximity to schools or daycares?
No, we don't have any research now, but of course we are very sensibilized with the situation. We want, as I said, our kids and our communities to be safe. So we are open, and we just want everybody in Canada to be safe, and people who need those facilities to have access to it.
Thank you very much. The next question actually comes from, came in before we started today. This question is for Brad Finewood. Brad, given your role as strategic advisor to the King County Public Health, how do you tackle systemic failures in public health that have allowed the opioid crisis to spiral out of control? And what do you see as the most significant barriers you face in implementing meaningful, lasting change, and how do you plan to overcome those?
Wow, what a good question. And I feel like
Easy
that's
answer.
yeah, right. I feel like that's a whole different panel discussion. But you know, I would open it up to any of my co-panelists to answer that too, because I mean, the truth of the matter is that the government has failed people, historically, in this situation, whether it's the war on drugs, which was also very much a war on people of color that have had disproportionate impacts on communities, marginalized communities over time. That it's really important to acknowledge that, right? Because if we don't start from acknowledging some of the harms that we cause, then we can't start to be alongside community and rectify the work. One of the things that we have done here is, again, come alongside marginalized communities and those communities that have been impacted. I shouldn't even say marginalized community. I should say communities really that have had disproportionate outcomes. As I was talking about earlier, our communities of color, both our Native community, our Black community, our Indigenous community, our people living unsheltered, really coming alongside them in program design and really supporting folks as we build programs out, because we know that if the programs don't work for the people who need them, and really bringing equity to the forefront, then we're going to continue to magnify the disparities and perpetuate the negative outcomes. And so it's really important for me in my work and the people that I work with to come along in a co-design model to bring people with lived experience to the forefront, to bring impacted communities. I used to work in prisons, and I'd walk into a prison to run a substance use disorder group, and I'd be the only light-skinned individual in the room. And there's something terribly wrong with that. I was the one leaving to be with my kids that day, while 10, 15 men of color were left behind, and the intergenerational impact of that impact on communities of color and in cities was insidious. And so really starting to work to undo some of those harms and come alongside the communities is for me the most important thing in my work.
Thank you very much for that, Brad. I appreciate it. Next question actually is an interesting one. It's a question to the ambassador. As a Canadian ambassador to Denmark, how do you perceive the differences in Denmark's approach to drug policy compared to Canada's? What lessons have you taken and learned from Denmark's harm reduction decriminalization efforts that could be applied to Canada, particularly in addressing the ongoing opioid crisis?
Well, I think as we were saying, here in Denmark, there's not necessarily an opioid crisis. It's more cocaine and a little bit of heroin, and they aren't seeing the overdose crisis in the same way. But I think I want to speak to what I have observed in terms of social determinants of health, where Denmark has been very, very effective in reducing poverty, in providing childcare, in post-secondary education, and therefore the decrease in crime. And so I just think that there's the hygge approach of family and friends and supporting one another is very, very effective. Nobody's more important than anybody else, and people don't actually are learning, I think, to respect one another and look after one another. But I think that here the the idea that there are street teams and the safe consumption site together with a treatment site, I think that we are seeing that the ability to get somebody immediately to talk to somebody who might be considering getting away from the hustle and the hassle is I think very interesting. Certainly what I observed this week at the safe consumption site in Copenhagen.
Thank you very much. I appreciate that. I think you spoke in your opening address the differences you're seeing between the two countries as well. I think, again, back to often we look at what's happening around us without realizing that it may not be the same for everybody. I just had a question come in, one of our listeners from Montreal. I was going to ask the parliamentary secretary, but I didn't get it in time. If you don't mind answering, is that okay, Dr. Bennett? Since a few months already, we see an increase in court cases attacking specifically some key elements of the Canadian drug supply, i.e. safe supply. And soon the Supreme Court of Canada will hear a case involving the Good Samaritan Drug Overdose Act, which is a police right to arrest or not arrest. Recently, Premier Ford in Ontario mentioned safe consumption sites were the worst things to happen to communities and decided to close most of them. We didn't hear much from the Canadian government's response to such dramatic decisions, and also toward the conservative opposition leader attitude and false information he is spreading. What can we expect from government as a clear response when we're actually entering into a pre-electoral year? I realize you're not answering as a politician, but I'm wondering if you have a perspective that you could provide about what you're seeing now around in some provinces when it comes to safe supply, supervised consumption sites. You're on mute, ma'am.
Sorry, I think that, you know, we watched for a while where harm reduction was sort of kicked out as one of the 4 pillars of drug policy in Canada. And as we get it back, and as we need to open, you know, our hearts and minds to doing things differently, and that people are dying. And so what are we going to do about that? But I think we've got to deal with the facts and the data, you know, as Jeremy said, that in BC, now with the BC Center for Addictions, we're trying to track the data around public safety, public health, public education, law enforcement, that we actually need to have the data, because I think the data is showing that there is that if you don't have safe consumption sites supervised, you have unsupervised consumption sites all over our communities. And so this is and that having, whether it's needles, whether it's all of the things that obviously communities are concerned about, that the existence of a safe consumption site, if you have the data, you can show that that goes down if there's a safe consumption site. So I think we need to increase the mental health literacy, and actually get away from just the rhetoric and the ideology, and be able to move in evidence-based, compassionate care. But I think, as Jeff said, we have to move on the investments that we know matter in terms of supportive housing and creating community where people will look after one another.
Sorry, thank you very much, and sorry for putting you on the spot with a semi-political question. You danced perfectly around it, around the political side. Dr. Turnbull, as the past medical director at Ottawa Inner City Health, how do you reconcile the medical community's ethical obligation to do no harm with the fact that many healthcare systems still fail to provide adequate support to those struggling with addiction? What do you see as the most critical change needed within the healthcare system to truly address the needs of people who use substances?
So that's a great question. It highlights the fact that there's many sources for this problem, and many institutions and organizations that have played a role in contributing to the problem that we're dealing with today. And the medical profession, organized institutions such as hospitals, etc., they have to become part of the solution. And they can no longer think that this is just something that's happening out in the community. It doesn't affect them. It affects them directly. It is their responsibility. And I think that when we start to shift our whole healthcare system more to the responding to the needs of a community, rather than isolated hospitals sticking out in the side and just sort of saying, well, we'll care for people who just come through our doors and that's all. We have to hold them accountable, doctors, other providers, institutions, and make them accountable for overall successes of programs that we've been talking about today. And they can contribute greatly, but they have to be part of the solution. And they haven't been.
Thank you very much, Doctor. I have a question that came in from one of our participants, and I'll read the question, and then I think Brad would like to provide a response, if that's okay. What can be done to make treatment more accessible to those on a wait list? What regulations are there for people struggling from addiction who utilize these overdose prevention services? These services can be used as an entrance to treatment, but not often. We lose people during that waiting time. Brad?
Yeah, thanks, Vern. This question is very personal to me. When I first started at King County, there was 50-person wait list for methadone, and one of the biggest successes that we had was advocating statewide to make sure that there was no caps or limits on treatment agencies. When people want treatment, we have to be able to provide treatment on demand. It just reminded me also of an anecdote when we had opiate task force in 2015 in King County. We had the director of our harm reduction agency, who was the biggest vociferous advocate for supervised consumption, come up to me after a meeting, and he goes, I really want supervised consumption here in Seattle and King County. But I'll tell you what, if the people who want access to methadone and buprenorphine that come into our syringe service program, into our needle exchange, can't get access, then you are a failure. And so no matter what, I think what we have to be able to do is provide access to treatment and treatment medications for people with opiate use disorder on demand when people want it, because if not, that window of opportunity comes and goes very quickly, and we might not see people again.
A great point. It's a real challenge. Look, it would be great if our communities and our cities and towns had enough resources that could actually deal with the multitude of addiction challenges that they're facing right now, let alone any of on top of that, if we look back to 2010, and Dr. Turnbull and I worked in the same city doing different work, but back then we thought it couldn't get worse. And we would take 2010 pretty quickly if we could, because it's gotten much worse. It's much more difficult, much more challenging, and many more different aspects to the drug addiction problem that we're seeing today than we saw back then. I want to thank everybody for participating today. First, I want to thank the panel. I truly appreciate you finding the time. An hour and a half goes by much more quickly than I expected. And I want to thank the people who actually attended as registrants and participants as well. My understanding is we will provide this this webinar on Pennington's website. Is that right, John? I think. But I want to thank Pennington for putting this on. It was truly appreciated. Never easy when you're looking at 12 hours, give or take, time difference between two locations in Ottawa and Australia. Melbourne, Australia, but truly appreciated the work that was put in. I'm going to call John Ryan in from Penington Institute now to wrap up. And again, I want to thank everyone for their participation. John.
Thanks very much, Vern. And yeah, I'd also like to thank especially the panel for contributing today. We're the conveners of International Overdose Awareness Day at Penington Institute, but we also just this week released Australia's annual overdose report. And that's partly because we are committed to evidence-based practice, but it's partly because if you don't count it, it really doesn't exist. And the problem in the Australian context in relation to overdose is because of much of the stigma, it's not talked about nearly as much, even though it is more than double the road toll now and has been bigger than the road toll for a decade. So we do have an overdose problem in Australia. It's particularly acute for people from Aboriginal and Torres Strait Islander backgrounds, more than 4 times worse per capita for that community. So it's a challenge, and it's a challenge even though we have what's described as a balanced approach between law enforcement or supply reduction, demand and prevention and harm reduction. Interestingly, the Australian population thinks that the law enforcement approach is not effective. Only 20% of people think that we can arrest our way out of these problems. Most of the community has moved on from that, but the budget allocation reflects historical patterns, which is that more than 60% goes to law enforcement and less than 2% of the drug budget in Australia goes to harm reduction. So it's a challenge and an ongoing challenge. Nonetheless, the International Overdose Awareness Day is very much about remembering those lost without stigma. There is an incredible silence around these issues, and we do want to acknowledge the many people that are impacted by overdose, those that are who's lost their lives, but also the families, friends, colleagues and neighbours who are left behind to grieve. Our real emphasis, though, is increasingly to try and accelerate prevention efforts in relation to overdose, and we rely on that, on our partners around the world as participants in International Overdose Awareness Day to prioritise in their own settings what they think is most appropriate. Those settings are incredibly diverse, and I think I really want to acknowledge those IOAD partners, particularly in low resource settings, who are often in very difficult political circumstances. Talking about these issues can really cause people trouble, and so our challenge as a global convener is to make sure that we're as inclusive as we possibly can, and I hope that we continue to see people talking more honestly, openly about overdose, and more honestly and openly about some of the solutions to overdose. That requires political leadership, and it also requires community leadership. And so in that sense, I'd like to thank the community and political leaders that have been on the panel today, but also to thank people who have joined us in this seminar. Most of all, thanks to Vern as a board member of Penington Institute, and also the Penington Institute team for putting this on. But the biggest thanks goes out to the IOID partners around the world. Last year there was more than 1,000 events in 40 countries. Not sure yet this year, but it's really that local action that makes the difference. And so I want to acknowledge all of that work. It's volunteer work. We don't financially support the participants, but we support them morally. And the theme this year is Together We Can, and I think that is really the essence of International Overdose Awareness Day. So thanks again, especially to the panel, and back to you, Vern. Thank you for chairing.
Thank you very much. We'll close out now. I hope everybody, wherever you are, either getting up and moving, Brad, or getting ready to go to bed. Some people, friends in Australia, and everyone else, please have a great weekend, and hopefully there are some events where you're living for the Overdose Awareness Day tomorrow, and please take care of everyone. Thanks again.
Thanks very much.